Hi, my name is Rosanna Marcella, and I am the Service Chief of Dermatology at the University of Florida. I graduated 11 years ago from the University of Milano in Italy, and after 2 years I moved to the United States, so I spent most of my professional career in the United States. I've been asked to do a dermatology review, and I'm doing this with great pleasure. Since the topic is really extensive, I decided to limit it to small animals, so I will be talking about small animal dermatology for the whole length of this tape. Here we go. I divided all the different diseases that I'm going to talk about in big categories. We will start with allergic skin diseases. Those are the most common ones that you will see in practice. Then I'll talk about parasitic skin diseases, bacterial infections, fungal infections, autoimmune diseases or diseases that are immune-mediated, briefly talk about some neoplastic diseases, and then endocrine and metabolic diseases. Dermatology is a big part of private practice. No matter where you will end up practicing, you will probably see between 20 and 80% of cases they have some kind of skin condition, and dermatology is definitely a big part of the board exam. So I suggest you to study this closely. We will start with the most common allergy, which is atopic dermatitis. And then I will talk about food allergy, contact allergy, and flea allergy. Atopic dermatitis is something that people get as well, and is actually a very common disease in kids. It is a genetically inherited disease, and that's true for both dogs and human beings. And is an IgE-mediated disease, which means it's type 1 hypersensitivity. Is an immediate reaction. So the best way to think about it is if you get an insect bite and you have a reaction, you will have an immediate reaction at 10-15 minutes after the bite. You might get a later reaction at 6 hours and maybe one the following day. But the one that you get at 10-15 minutes is the IgE-mediated response, which is an immediate reaction. And that's the one that is important in atopic dermatitis. As far as typical age of onset, these are young animals. They're usually between 1 and 3 years of age, and that's true if they live all their life in the same environment. So I practice in Florida, and the typical Florida dog will come with clinical signs between 1 and 3 years of age. Some dogs are really bad, and they may develop clinical signs at less than 1 year of age. They may start as young as 6 months of age, like Shar-Peis or bulldogs. But the vast majority of dogs is between 1 and 3 years of age. It's a different story if you have an animal that moves from one geographical area to the other. In that case, let's say you have a dog that lived in Nebraska, Montana, some kind of cold climate, and then they move to Florida. They might be 10 at the time that they move to Florida. In the first season, it's not that bad, but then, as they spend more time in a warm climate, they will develop clinical signs. So initially, they're seasonal. They might be bad in spring and summer, and then as the weather gets colder, they get better. As far as warm climates are concerned, most of the ones that we see, they tend to become all year round fairly quickly. If you will end up practicing in an area that is fairly cold, you may still have a seasonality. The main difference between allergies between dogs and people is that dogs tend to get worse with age, while people usually tend to get better with age. So allergies are really bad in kids. And then as you get older, the symptoms decrease. As far as clinical signs, the main one is itching, pruritus, and then you can have erythema, which is redness. So at the very beginning, you will have an itchy dog, and it's usually face, feet, and ears. And when you look at the skin, you will not see anything. But the dog is itchy, and so it's spending a lot of time rubbing the face against the carpet and the furniture, licking and chewing the feet, and then scratching the ears. And as a consequence of that, they will get recurrent skin and ear infections. And there are mainly two types of infections. They can either be bacterial or they can be yeast. Sometimes a combination of both bacteria and yeast. I have here some pictures for you. This is a Basset Hound, which is a commonly affected breed, and you can see this dog has done some kind of face rubbing. You have a bit of periocular alopecia, a bit on the face. Definitely he has pruritus on his legs. He has been licking and chewing on his front feet, and then as he has gotten progressively worse, he's doing all 4 feet. So they usually start with the front feet first. And now he is developing also a secondary infection, and just looking at this dog, it looks like both bacterial and yeast infection. It's another dog here, and this dog has what we call salivary staining, which is that kind of discoloration of the hair and the skin. This is very easily seen in dogs that have white feet, and you will see that rusty color, kind of reddish discoloration. It tells you the dog has been licking and chewing on its feet. And then they get secondary yeast infection like this dog probably has. This is another dog, and this is actually very obvious. You have periocular alopecia. So this dog had been rubbing his face, and so the hair loss comes from the rubbing, and the erythema is just primary. So it's primary redness due to the underlying disease process. And like golden retrievers, they're prone to get allergies, so it's a very common breed for that. So how do you make a diagnosis of atopic dermatitis? The most important thing is clinical signs, and then exclusion of other pruritic diseases. There are other skin diseases that can look like atopic dermatitis. For example, food allergy looks exactly the same. You have face, feet, ears, they have pruritus, they have secondary skin infection, and just by looking at the dog, you cannot tell them apart. So it's very important that you rule out other pruritic skin diseases. And as I talk about food allergy, I will explain to you how to rule out food allergy before you can consider diagnosis of atopic dermatitis. Especially if the pruritus is all year long and you don't have a good history. If you have a history of seasonal pruritus at the beginning that got progressively worse, then you can make a diagnosis of atopic dermatitis right from the start. There are some testing that you can do, but usually people put too much emphasis on this test. And you can do skin testing, which is what specialists usually do, because the allergens are expensive and they expire rapidly, so it's not something that you will be doing in practice. Serology testing is more easily available. You draw some blood, you submit it, and you're basically looking for circulating IgE. The drawback of this testing is that you can have false positive results in normal individuals. So for example, I can have a dog with scabies, and I do skin testing, or I do serology testing, and they come out positive. That does not make that animal atopic. The only thing that it tells me is that that animal has IgE against whatever allergen I'm testing it for, but by itself is not sufficient to make a clinical diagnosis of atopic dermatitis. So you should never put too much emphasis on your testing. You should look at the dog, consider the history, and make sure that you are ruling out other pruritic skin diseases. Now, what about therapy? One important thing to remember in dermatology is the threshold phenomena, which means that in dermatology, you usually have several diseases going on in the same animal. For example, it's not unusual to have multiple allergies in the same animal because allergies are a genetic predisposition. So an animal that has atopic dermatitis has higher risk of developing flea allergy, food allergy, and other allergies. On top of that, they get secondary skin infection. And so everything adds up. So a bit of bacteria, a bit of yeast will make that animal more itchy and will add on the underlying allergy. So when you have an allergic animal, the first thing that you should do is, number one, make sure that it doesn't have a secondary infection, and if it does it, then you have to address it, and then see whatever is the pruritus that is left, and then see if it has flea allergy. If it does, you have to control the fleas, make sure you're not missing a food allergy, and then you're left with the atopic dermatitis. And as far as treatments, there is a list of symptomatic treatments. The most commonly used is steroids. I strongly recommend only oral steroids because it's something that you can regulate more readily. So if the animal has any kind of side effect, you can stop it. And also, you have less adrenal suppression. If you give an injection, you may have prolonged adrenal suppression even for months, especially if it's a repository formulation. The problem with steroids is that they work very well at the beginning, and over time, they stop working. So you're left with other treatments, which are usually not as powerful as steroids. That's why steroids should be used in a very limited way, and you should explore other alternatives. The other thing that steroids do is they make infections more likely to reoccur and resistant to treatment. So I always discourage people from using steroids and antibiotics at the same time. Then you can use antihistamines. Antihistamines, there is a long list of different antihistamines that you can try. They belong to different categories, and different dogs may respond in a different way. So you can use Benadryl, you can use Atarax, you can use chlorothalonil. And what I usually do, I go through the whole trial. I try each one for 2 weeks and see how the dog does. If there is no response, then I switch to the next one. As a general rule, antihistamines are metabolized more quickly in dogs, so we tend to use dosages that are much higher than what people would normally use. To give you an example, if you use Benadryl, people use 25, 50 milligram of Benadryl as a sleeping pill. Well, in dogs, the dose is 1 milligram per pound. So if you have 3 times a day. So if you have a 50-pound dog, you can give him a 50 milligram Benadryl 3 times a day, which basically would put all of us to sleep for a long time. So dogs tend to metabolize antihistamines more readily. Then you can combine them with essential fatty acids. There is a variety of fatty acids that you can try. And then if the animal has a long season, then we try hyposensitization, which is basically allergy vaccine like they do in people. Once you have the results of your skin testing or serology testing, you pick the allergens that you think are clinically relevant for that animal, and you make up a vaccine. The success rate of hyposensitization is between 70 and 80% in dogs, especially if you start in young animals, but it takes time, between 6 and 9 months before you can really see the full improvement. And most of these dogs will require hyposensitization for the rest of their lives. Then there are some new treatments, and I don't know, somebody might ask you questions about that. We have been using cyclosporin now for about a year. We use a dose that is lower than the immunosuppressive dose. And so immunosuppressive, you would use like a 20 milligram per kilogram, and as far as dose for atopic dermatitis, we use 5 milligram per kilogram. Cyclosporin is a strong immunomodulating / immunosuppressive agent, so there is a potential for problems. At the lower dose, we have never had problems, but you probably want to check CBC and chemistry on a routine basis if you have patients on this medication. And then misoprostol, Cytotec, is another drug that has shown to have some kind of anti-allergic property. by itself is not strong enough, and you have to combine it with something else, possibly antihistamines. And then pentoxifylline. Pentoxifylline is a drug that has been on the market for a long time for people, and it works by suppressing tumor necrosis factor alpha, interleukin-1, and interleukin-6, and those are all pro-inflammatory cytokines. So it has anti-inflammatory and anti-allergic properties. So if you use it 15-20 milligram per kilogram twice, 3 times a day, is a fairly good anti-inflammatory medication. You may use it by itself or in conjunction with antihistamines. Now we're done with atopic dermatitis. We're moving to food allergy. Food allergy is not nearly as common as people may think. There's been a lot of pressure, especially from companies producing dog foods, to make it sound like it's such a common allergy, but in reality it's not. So if you see 100 itchy dogs, 95% of them have atopic dermatitis and only 5% of them have food allergy. But it's something that you should rule out, especially if the history is not clear and you have non-seasonal symptoms. It can start at any age, and that's the main difference between atopic dermatitis and food allergy. When we talked about atopic dermatitis, we said it's usually between 1 and 3 years of age. So if I have a really young animal or a really old animal, I should probably put food allergy higher on my list of differential. So the other thing, you don't need to change the diet in order to have a food allergy. Actually, 70% of dogs with food allergy have been fed the same diet for over 2 years, which makes sense. It means that it takes time for an animal to build a hypersensitivity. But people don't realize that. So when you talk about food allergy as a possibility, the most common thing that people say is that I've been feeding this diet for a long time, so it cannot be food allergy, and that's wrong. It's usually a pruritic disease. It can look like atopic dermatitis, so you have itchy face, itchy feet, itchy ears, recurrent skin and ear infections, exactly like atopic dermatitis. The main difference is with food allergy, you may have perineal pruritus, means tail, back legs, and all the perineal area. So we say ears and rears. And that's different from atopic dermatitis. So it's more the area where flea allergic animals are itchy. Here are some pictures. This is a dog that was diagnosed with food allergy, and once again you can see that the animal has some periocular pruritus and has been grubbing. So you have alopecia on the muzzle, and this dog had also ear infection. This was a dog obviously very itchy, was itchy on his feet, had been traumatizing his feet. And I don't know if you can appreciate that, but there is a rusty discoloration in the nails. So these nails are supposed to be white, and they have that kind of rusty, reddish color. And that is a symptom of malassezia, infection of the nail bed. So malassezia is a yeast we'll talk about in a minute, and that's very common in dogs with allergies. So how do you make a diagnosis of food allergy? You have to do a food trial. There are tests on the market. You can do serology testing, and some people do skin testing for food allergy, but the truth is that they don't work. When they've done studies and they looked at the positive predictive value, which means what are the chances that the animal is truly allergic to beef if you have a positive serology to beef, the positive predictive value was less than 50%. It's almost like saying if I have a positive serology for beef, it's actually unlikely that the animal will have a clinical allergy for beef. So now we do food trial, which means that you have to select something that a source of protein and a source of carbohydrate that is brand new for that dog. So over the years, we have been looking for unusual types of meats. And that's why now we have, in the United States, we have venison diet, we have a rabbit and potato diet, we have kangaroo and oats. We have all kinds of bizarre diets, and that's why we're looking for something that the animal has never been exposed to before. And then feed that diet with no treats, no snacks, nothing else for 2 months. So it's not sufficient just to do a diet switch. Sometimes people just change from one brand to the other, and that really doesn't help because a lot of ingredients are in common. There are only a few brands that you can use for a food trial. It has to be a clean diet. A lot of diets, they say slim and rice, and then you read on the label and there's all kinds of ingredients. So in the United States, the clean diets are IVD, which is Innovative Veterinary Diet, Nature Recipe. Waltham has some good diet. Science Diet, I mean, there are some from Hills that you can use. And now we have had hydrolyzed diet in last year or 6 months, and I'll cover those in a minute. So when you do the food trial, basically what you're monitoring is the pruritus, which is the itching, and the recurrence of infection. So it's very important for you to know how often that animal tends to get, I don't know, a ear infection. So you have to get that from your history. So let's say this dog gets a skin infection once a month. And so what you're trying to do is to see if I cleared infection and then I change the diet, can I make this, can I make him go 2 months, 3 months, 4 months without any infection? So that's the key. And then let's say that for 3 months this animal has no infections, but you've also been doing other things. You've been doing flea control, you've been very good with bathing and everything else. How do I know that this dog truly has a food allergy? And the key is that you have to go back and re-challenge him and see if you have any worsening of clinical signs. Okay, so it's not enough that you just change the diet. That animal might have inhalant allergy and it's just going out of season. It's winter time, so it looks like everything is great and everybody's saying it's food allergy. You have to go back and re-challenge. And then just a few words on hydrolyzed diets, because you might be asked about it. There are several ones that we have here on the market in the States. One is, the most recent is ZD, which is hydrolyzed chicken, but there are several other ones on the market. And basically the theory behind the hydrolyzed diets is that if I make the protein very small, that molecule is so small that it cannot cross-bridge to IgE molecules on the mast cells, therefore cannot trigger mast cell degranulation. So remember, we're still looking at mostly type 1 hypersensitivity, which is IgE mediated, and the idea behind that is that if you produce IgE and this IgE bind on the mast cell, upon re-exposure to the same allergen, the allergen binds to the IgE, and if you have cross-linking of 2 molecules, that's sufficient to trigger mast cell degranulation. Now, if the molecule is small enough, it cannot link to IgE, therefore you have no symptoms. So that's the theory. The problem is that a lot of these proteins, let's say you hydrolyze the molecule, but once you put it in the bag, these molecules tend to reaggregate with each other. Therefore, the size does not always stay as small as it is supposed to be. That's why we don't recommend hydrolyzed diet for diagnostic purposes when you don't know if the animal has a food allergy or not. Once you have your diagnosis, you can try those diets to see if you can control an animal on that specific diet. But I've had several animals that were diagnosed with a certain food allergy, for example, chicken, and then you put on a hydrolyzed chicken diet and they flared up. So obviously something went wrong. So I wouldn't recommend you to use these diets, but they're on the market. You may be asked questions on it, and I explained to you what's the rationale behind these diets. And the hydrolyzed diets are kind of commonly used in infants with milk allergies, and that's where the idea comes from. So therapy for food allergy is avoidance. You could try to use steroids, but a lot of dogs do not respond to steroids, so definitely it's an allergy that you need to diagnose and just avoid whatever offending food is responsible. Since it's a genetic thing, you may have animals that over time develop more and more food allergies. Contact allergy is a type 4, which is cell-mediated, is delayed. It's like poison ivy. You go in the woods, and it takes 1 or 2 days before you have clinical signs. And it's an itchy disease, extremely itchy, and it is a papular disease, which means you have red bumps. And then you get secondary infections, and you diagnose it by doing either confinement or doing a patch test. Confinement means that I wash the dog and confine him in a cage for a week, 10 days, and then all the symptoms go away. If that had been an inhalant allergy, the animal will still have clinical signs. But since I'm preventing contact with whatever offending plant or a carpet or whatever substance is, the animal will get better. Or I can do a patch test, which means I physically apply a sample of carpet fiber or plant on the skin, put a bandage on, wait 24 hours, remove it, and look for a reaction. I have here some pictures. Some showed up okay and other ones didn't, so I'll try my best. Here you see these little red dots, little papules, and this dog had it all over on his arms and underneath his belly. And so he had a contact allergy to carpet. And that's the same dog, and had a bit of a papular eruption here on the ear, had it here on his face, around his eyes, on his neck. It was intensely pruritic. And this one is probably the one that showed up best. You have this tiny little papules, red dots, very, very itchy. So that was all contact allergy. The same on the foot. You can appreciate it was obviously redness, and the dog was very itchy, and then you have this tiny papules. And so that is something that is very typical of contact allergy. Therapy, again, avoidance would be the best thing. You can try to use steroids, and they usually work, at least initially. Or you can try pentoxifylline. And pentoxifylline is what they use in people, say people with poison ivy. You know you're going to be in the woods. You start pentoxifylline treatment 2 days before you go out. And so it has a protective effect. Now, antihistamines would not work because contact is type 4, hypersensitivity, which is cell-mediated, while the antihistamines work for type 1, which is IgE-mediated. So there are different types of diseases, and that's why for atopic dermatitis we use antihistamines. For contact allergy, we cannot use antihistamines. Steroids will work for both. And then flea allergy, very, very common. The pathogenesis is a combination of hypersensitivity, both immediate, which is type 1, and delayed, type 4. As an itchy disease, you have papules. You can have hot spots, very common. The proper term is pyotraumatic dermatitis. And the distribution is rump, legs, back tail, back legs and tail. Diagnosis, you make it by clinical signs, and you can do intradermal skin testing. And therapy should be mainly avoidance, which means flea control. And you can use steroids as an adjunctive treatment. I have here some pictures, just to show you the distribution. This dog is clearly rump and had tail, so it had nothing else in the front of his body. Very itchy. This one had a hot spot. And so you clip it, you clean it, and then you realize how extensive the lesion is. That's very, very pruritic. I have some information on flea controls just to give you an idea what's on the market. Somebody might ask you. There are things that you can use on pets, and you can use the adulticides, which is what most commonly people are doing now. You can combine with insect growth regulators, or you can use chitin inhibitors. Just as a general thing about fleas, a few facts to remember. Most of the adult fleas, you find it on the host. But if I find 5 adult fleas on one dog, it means that I have at least 1,000 immature stages in the environment. So the flea control should be devoted not just to kill the adult fleas on the animal, but also to get rid of the immature forms, which means eggs, larvae, and cocoon in the environment. And then hatching is triggered by vibrations, which means that if you go in the house and it's been empty for a while and you start walking on the carpet, you have all these young adults and they will all emerge and they will be looking for a blood meal. And that's why a place that might have been empty for a long time and nobody lived there, no animals, and then suddenly you have a flea infestation. They do not survive direct UV light, so if you have extensive area to treat, let's say outside environment, only focus on the areas that are shaded areas where there are trees and there is no direct light penetration. And then the ideal temperature, 65, 75 Fahrenheit. Several products that we have currently in the United States available to kill adult fleas. The popular Frontline, it comes as a spray or as drops that you apply on the animal. You can use Advantage, is also an adulticide. They're both monthly products. The difference between Advantage and Frontline, Advantage only kills fleas. Frontline kills fleas and ticks. Advantage is rapidly washed off, and Frontline tends to stay on the coat after a bath. But you have to, if you use Frontline, let's say you give a bath today, then you have to wait 24-48 hours before you apply Frontline. And once you apply Frontline, then you have to wait another 24-48 hours before you can give another bath. And that's to allow enough penetration of the product on the in the sebaceous glands. And then you have Revolution, which is heartworm prevention, flea control, kills mites. For fleas, is not a great product. I guess it's about 80% effective, so its general flea control is okay. If you have a flea allergic animal, you need to use something stronger. And then Capstar is a pill that you give, and it kills fleas within 30 minutes. But it doesn't have a residual activity, so you should basically give it daily, which is not a very effective treatment long term, and is not the best thing for flea allergic animals because the flea has to bite the dog to get the medication so that they can die. So, if you have a flea allergic animal, that animal is going to be itchy even after the flea dies, just because they are allergic to the flea saliva. And then you have pyrethrins, permethrin, a lot of products that are a combination of both. Permethrin, if you use high enough concentration, is a repellent. At 2% is a repellent. It's very safe for dogs. It's toxic for cats. And then you have IGR, which are insect growth regulators. So they don't kill the flea, but they prevent them from reproducing. You can have the methoprim is the oldest one, and is an okay product, but is inactivated by UV light. So if I have a collar that has methoprim and the animal goes outside, it's inactivated. So it doesn't have much use. Or you can use, the newest one is pyriproxyfentanyl, which you can find in collars or you can find in a spray, and it's resistant to UV light and it lasts for a long time, 4 months. You can use chitin inhibitors like Program, and is a very good thing to use, and I do recommend to alternate products or to combine Program with an adulticide, just because we are seeing more and more resistance. And the only limitation with Program is, number one, there is a lag phase. before you see the improvement. So if I start a program today, it's going to take probably 3 months before I have a flea-free environment. The other problem is, again, the flea has to bite the dog to get the program, and then it will not be able to have, the eggs will not be able to hatch, which is too late for the flea allergic animal. And it works best in a confined environment. So if you take the dog for walks, then program is not the best flea control. And then you have products for the outside environment. You can use, again, IGR, like pyriproxyfen, pyrethrin, permethrin, and then the beneficial nematodes, which are nematodes that actually kill fleas, something that is sold in granules. You mix it with water and you spray in the yard. The only limitation is the nematodes need to have a moist environment. So if there is a long period of drought, they will die. They don't reproduce, which means that you have to reapply them, and they don't move very much. So you have to apply them exactly where you need them. And then for the inside in the house, you can use sodium polyborate, or a combination of IGR, pyrethrin, and permethrin. Sodium polyborate is especially good for carpets. So there are companies that do this, and they apply directly in the carpet, and they guarantee it for a year. Fleabuster is one company that does this. Let's move to parasitic skin diseases. We have only two. They're really important. One is demodicosis, and the other one is scabies. Demodex, that is a big, important disease to know. Demodex is part of the normal flora, but there are some dogs in which there is an immunological defect which has not been cleared yet, and therefore these dogs are not able to keep the mite count under control, and they have the mites proliferating, and they develop skin lesions and disease. There are a few things to know about Demodex. One is the life cycle is 3 weeks, which means that if you have eggs on the skin scraping today, you're going to have mice for at least 3 weeks after that. And there are 4 different life stages, and you may be asked to recognize the different life stages, so you need to be familiar with how the eggs, the larvae, the nymphs, and the adults look like. The egg is easy, and I have a picture of that. The larva is also easy because it's the only one that has 3 pair of legs. And the nymph and the adult has 4 pair of legs. So if you start counting the legs, you should have no problem. As far as clinical syndromes, you can have the juvenile onset. And the juvenile onset can be localized or can be generalized, or you can have the adult onset. And we say juvenile if the animal is less than 2 years of age, adult onset if it's older than 2 years. The localized juvenile form is a benign form, so there is nothing genetically wrong with those animals. They just get stressed and they develop patchy hair loss. It is usually one region on the body. It's usually on the face or on the feet. And 90% of them, they spontaneously resolve. They don't develop any further skin disease later on in their lives. And so these animals can be used for breeding. There is nothing wrong with them. However, 10% of them will progress into a generalized form, and that's a completely different disease. These animals have a genetically inherited disease. They should not be used for breeding, and they might still clear spontaneously, 50% of them, but even the ones that spontaneously clear, they still have the genetic defect, and they will transmit this deficiency to their puppies, so they should not be used for breeding. Clinically, demodicosis shows up as a folliculitis, and then which means papules and pustules and epidermal collarettes, and you may see comedones, which are blackheads, so you have like little black dots, and then secondary infection. And the feet are commonly affected. So this is a picture to show you that gray discoloration that is very common with demodicosis. So when you see that kind of grayish color, you should always scrape the dog. Even if you don't have hair loss, like in this case, the dog had demodex and it was not losing the hair, but already had this change in pigmentation. This dog had deep pyoderma on his feet and had demodicosis. So if you have an animal with pododermatitis, demodicosis should be one of your first differentials. So I see a dog like this, I said, well, definitely has a deep infection. I see all the swelling. And then I say, well, demodex is one of the possibilities. The other possibility is that I have allergies, like either atopy or food. It could be a contact. It could be a fungal infection. But demodex should be one of your first differential diagnoses. And again, deep skin scraping is what you need to do to make a diagnosis. And this is an adult, has 4 pair of legs. This is an egg. And that's as much as I can see on this slide. Now, if you have an adult dog, then it means that there is an underlying disease. So this is not a genetically inherited disease. It means that it has some other condition. So that is getting immunosuppressed and is developing demodicosis. So you have to look for an underlying tumor, either hypothyroidism or Cushing or too many steroids or some other condition. As far as treatment, the only FDA-approved treatment in the United States is Matiban. And the approved treatment is 1 dip every 2 weeks. Now, this is a legal treatment. However, they've done studies and it has been proven that if you use it once a week rather than once every 2 weeks, it works much better. But according to the law, you should use it once every 2 weeks. You should prepare it fresh every week. And as far as side effects, the most common is sedation. You may have other side effects, but sedation is the most common thing you'll see. And then there are other treatments that we use routinely, but they're not approved. So you have ivermectin. The only legally approved use of ivermectin in the United States is hormone prevention, but people use it for other things. And demodex is one of them. And we use a very high dose. 400 to 600 micrograms per kilogram daily. To give you an idea, the heartworm prevention dose is 6 micrograms per kilogram once a month. So this is a much higher dose, and obviously you should not use it in collies or in breeds that are sensitive to ivermectin. The toxic dose for collies is around 100 micrograms per kilogram, so this is much higher. And then you have milbamycin, which is the same family of drugs, and is 1.5 to 2 milligrams per kilogram once a day. And then you should use antibiotic because the pyoderma, which means the bacterial infection, is very common with demodicosis. And you have to monitor the improvement. And we scrape these dogs once a month, and then we record the findings. And ideally, you should have 3 consecutive negative scrapings before you can discontinue treatment. The second parasitic disease we're going to talk about is scabies. Scabies is contagious. That's different from demodex, which is not, and is a very itchy disease, and is a papular disease. The life cycle is like demodex, 3 weeks. It's not host specific, which means that a dog can get scabies from people, and people can get scabies from dogs. So even if they have slightly different mites, we can kind of exchange mites. However, if I get scabies from a dog, that mite will not be able to reproduce on my skin. So I will get an itchy rash, but within 10 to 14 days, the mite will die, and that will be the end of the story. Mites also do not survive for very long in the environment, so usually environmental control is not a big issue. And you have primarily a ventral distribution, ventral abdomen, pinna, hocks, and elbows. And this is just how it looks clinically. You have this papular eruption here on the ventral abdomen, and it's intensely pruritic. And this, again, you can see the escalation due to the intense pruritus. Diagnosis, you can do the scraping and see if you find the mites. The problem is that most of the times the scrapings are negative because the dog becomes hypersensitive to the mites, and so very few mites are sufficient to cause severe clinical signs. So most of the times the dog has 2 or 3 mites appear on the whole body, and the chances of you finding it with the scraping is very low. So we do response to treatment. And as far as treatment, you can do lime dip, which is something you find in the United States and you don't find in other countries. It's lime sulfur once a week for at least 3-4 times. You can use Revolution, which is approved for this use. We have seen some failures, but it's legally approved. And then you have non-approved treatments. You can use Garamactin, and the dose we use for scabies is 250 to 300 microgram per kilogram once every 2 weeks for 3 times. Or you can use Nobamycin. Frontline will also kill scabies, or you can use Midaben. So if you have a dog that has Demodex and scabies, you can basically kill both of them just by using Amitriptyline, which is Midaben. It's important that all the animals in contact are treated, and that you treat long enough to cover the whole life cycle. Let's talk about bacterial skin infections now. The most important is pyoderma, which is usually staph-related. It's usually secondary, and you can have a superficial infection or you can have a deep infection. So the superficial is what we call folliculitis, and deep one is bronchiolitis or cellulitis. Now, if somebody asks you what are the 3 most common causes of folliculitis in the dog, you have definitely Staphylococcus, then Demodex, and dermatophytes. Those are the 3 important ones that you really need to know. As far as clinical signs, so pyoderma is usually hair loss. You can have a papular eruption, and then you have epidermal collarettes and hyperpigmentation. So this is how the pustule looks like. You have erythema all around it, and it's filled with this blister-looking lesion is filled with pus. This is a macule. The pustule is very transient, so it doesn't stay there very long. This dog has generalized clinical signs of redness and hair loss. And as far as treatment, okay, if you have a superficial infection, then you have to give the antibiotic for at least a month, 3-4 weeks. And then we also prescribe topical therapy, usually like benzoyl peroxide shampoo. And then you have to figure out the underlying cause. Why is this animal breaking with an infection? Because 99% of pyoderma is secondary to something else. Most commonly allergies, but it could be something different. And if you don't figure that out, that animal is going to relapse with infections over and over again.